live. Patricia, please confirm that we are indeed live.
Yes, checking online. Kindly give me a bit of like 5 minutes for it to load on my end.
Sure. Dr. Mwendwa, are you on? Can you hear us clearly?
Thank you, Dr. Aisha. Yes, I'm on. I'm unable to start my video though, because I think some host restrictions.
Sharing. That's okay.
Yes.
Let's just confirm that we are actually live on Facebook, as last week we had a bit of a delay.
Yes, Doc, we are live on Facebook.
Fantastic. So
yes,
good evening
Dr.
again,
Aisha,
everyone. Thank you so much. So good evening again, everyone. I am Dr. Aisha Bianca Edwards-Remy, Head of Clinical Services at AAR Hospital. Today is World Childhood Cancer Day, and we are commemorating this day with a live webinar on anemia in children, with our speaker being Dr. Catherine Wendell. So Dr. Catherine is a pediatric hematologist and oncologist who recently completed her fellowship training at Macquarie University in collaboration with Molago National Referral Hospital, Baylor College of Medicine, and Texas Cancer Children Hospital. She's currently working as a consultant pediatrician at Bagadi County Hospital in Nairobi, as well as an admitting consultant here at AAR Hospital, which is along Kiambu Road in Nairobi. She received her medical degree and her postgraduate degree in pediatrics and child health, both from University of Nairobi. She's enthusiastic about improving the outcome of children with blood and cancer disorders in Kenya through novel intervention that are sustainable in a resource-limited setting. As I said earlier, I believe that it's not just limited to Kenya, it's a global reach that Dr. Catherine has. So Dr. Catherine, Karibuni sana. I will stop sharing my screen and allow you to present. Just a bit of housekeeping. If you have any questions, feel free to put them in the chat or in the Q&A section, which we will address at the end of Doc's presentation. Dr. Terry?
Thank you so much, Dr. Aisha, for the kind introduction. So I'm not going to introduce myself again, but I would like to say that I'll just like to reiterate what you mentioned, that every 15th day of February, we celebrate the International Childhood Cancer Day. And this is a global collaborative campaign to raise awareness about childhood cancer and to express support for children and adolescents with cancer, their survivors and their families. This was conceptualized in 2001 by the Childhood Cancer International. So the theme for this year is better survival is achievable through your hands. And so that means that the focus is actually paying a tribute to the medical team and the healthcare workers and the positive impact they have on the lives of these children and adolescents with cancer. And also the International Childhood Cancer Day, it highlights the need for more equitable access to treatment and care for all children with cancer everywhere, regardless of where they live in the world. So in that spirit, I chose this topic on approach to childhood anemia because it's an important and global public health problem, especially in developing countries like Kenya. And even as a pediatrician or a healthcare worker, you come across children with anemia in your everyday practice. So it's important to have early recognition, treatment, and so as to improve the outcomes of our children. And even for the parents and the guardians that are listening in today, I know for some, you might have experiences where at one point you heard that your child has low blood or low hemoglobin. So basically they have anemia. So I think this is a very relevant talk to you too. So to start us off, The outline of this talk, which we look at introduction, some definition, classification of anemia, clinical presentations, the laboratory investigations, and we'll finish up with some case scenarios. So anemia definition it's defined as a hemoglobin concentration or red blood cell mass less than the 5th percentile for age, or less than 2 standard deviations below the normal mean for age. So what does it mean? It means that there is no absolute cutoff value that really defines anemia, because it varies by age, it varies by gender. So usually there are some tables like this one. I lifted it up from the Harriet Lane handbook, and this table it gives you an idea of the average mean values and the lower limit for 6 parameters. From the extreme left, you can see hemoglobin in grams per deciliter, packed cell volume in percentage, or what we say as hematocrit, the red blood cell count, the MCV, which is the mean cell volume or mean corpuscular volume, the mean cell hemoglobin, the MCH, and the mean cell hemoglobin concentration, the MCHC. So what you can see is neonates at birth, they have higher hemoglobin. You can see the mean, that is on average, they should have a hemoglobin of about 16.5 grams per deciliter, with the lower limit being about 13.5 grams per deciliter. And we know because in utero, the neonates, they use a different type of hemoglobin, the hemoglobin F, fetal hemoglobin, which predominates, and it has a higher oxygen affinity, and thus the higher hemoglobin is required for oxygen delivery. And due to postnatal decrease in oxygen affinity once a child is born, the hemoglobin actually drops in the next several days, and you have a physiological nadir around 2 months of age. So if you look at this table at 2 months, then the hemoglobin actually goes down to about 11.5 grams. That's on average, with a mean of with a lower limit of about 9 grams per deciliter. And it is even more exaggerated in preterms, because we know preterms actually have higher hemoglobin at birth, and the drop is much more exaggerated. So this table is here for your reference when you're seeing patients in the clinic, or if in your daily practice. Yeah, it's quite wordy, so I won't go. It has a lot of value, so I won't go through with it. But also, I picked up a table from the World Health Organization, WHO, and it actually puts up the lower limits for hemoglobin and hematocrit by age and gender. So again, you can see they've clustered the ages of these children between 6 to 59 months. The hemoglobin, the lower limit should be about 11 grams per deciliter, with a hematocrit of 33%. And for the much older children, the adolescents, girls aged 15 years, boys aged 15 years, their lower limit of hemoglobin should be 12 and 13 grams per deciliter, respectively. If you do not have access to these tables, then there is some, what can I say, formulas that you can use. Especially they come in handy when you're in your busy clinical practice. So what we know is for children less than 10 years, and you just want to eyeball this complete blood count and see whether the hemoglobin is fine, you'll see you use the formula 11 plus in brackets 0.1 times the age. And I give an example for like a 3-year-old, then the constant is 11 plus in brackets 0.1 times age of 3, that becomes about 11.3 grams per deciliter. So the lower range of hemoglobin for this 3-year-old child should be 11.3 grams. So anything lower than that, then that means the child has anemia. MCV is the measure of the red blood cell size, and it's actually very useful to determine what type of anemia it is. So also the MCV, there's a quick guide for it. You take the lower limit of MCV to be 70, and then you add the age in years. So in a child who's 3 years old, then the MCV, the mean cell volume, should be about 73 femtoliters, meaning anything lower than that, then that is a lower MCV. So that is just a quick guide for those who like formulas and calculations. So why do we worry about anemia? Anemia during childhood actually affects the mental, the physical, and social development of the child in both the short term and the long term. So it causes poor motor and cognitive development. So the children tend to have poor growth. They tend to have developmental delays, not only in the motor, the speech, and the cognitive. It causes abnormal immune function, so they are at increased risk of infections. It also causes poor school performance and reduced work productivity in these children's lives. So that means even as they grow up, as they're trying to get jobs, that reduces their earning potential, because probably they did not excel so well just because their IQ levels are not as optimum as they should be. And in the long term, it actually negatively affects the national economic growth. So you're looking at short-term and also long-term outcomes. When severe enough, it can cause premature deaths. And so this is actually from the CDC. So how do you classify anemia? You can classify anemia morphologically. That means you look at the structure of the red blood cells. So the structure meaning the size. So one way you can look at is the mean corpuscular volume, the mean cell volume. That is the measurement of the red blood cell size. This, you can be able to pick that up from a routine complete blood count. So the normal MCV should range about 80 to 100 femtoliters. So that is what is called normocytic. So if it's low, less than 80, then that is microcytic. And if the MCV is greater than 100, then that is macrocytic. So you can actually classify the anemia based on the morphology. You can also classify this anemia based on the etiology, and we shall come back to the etiological classification of anemia. So looking at the morphology, because MCV, you can get an idea through the complete blood count, but also you can look under the microscope, do a peripheral blood smear. So basically what that means is you take a sample of blood from the child, and then you smear it on a slide, stain it, and then look at it under the microscope and see how the red blood cells appear. But also, as you can see in this slide, I hope you're able to see the pen. Dr. Aisha, are you able to see the pen?
Yes, we are.
Okay, great. So this is just a section of a peripheral smear. And what you see is one cell that has like a purplish nucleus with a bluish cytoplasm surrounding it. So this is a small lymphocyte. This is sort of like what benchmarks how the size of your red blood cell. So surrounding this small lymphocyte, which is a type of an immune cell, then you see the red blood cells. The red blood cells have a pale center, which should be about a third of the total of the red cell size. And then the third cell line is the platelets, which look like that on the peripheral slide. So these are platelets. They help the blood to clot. But the focus for today, we're looking at the red blood cells and how they appear in different conditions. So basically in this slide, if you appreciate the red blood cells, they almost look uniform. They almost look the same. They are almost the size of this small lymphocyte. You look at the nucleus of the lymphocyte. And so these red blood cells are normocytic because the center is a third of the size of the red cell. So that makes it normochromic also, the color of the red cell. So in situations where you have anemia and you see a smear that looks like this, so this is a normocytic normochromic anemia. MCV would be about 80 to 100 with an MCH at 27 to 31 picograms. So situations that can bring about such anemia would be the potential causes would be things such as blood loss, whether it is acute or chronic. It has occurred at that time or it has been slowly occurring over time. Anemia of chronic illness, probably you have a certain illness that is bringing about the anemia. Chronic infections, sorry, there's a typo there. Systemic diseases, and also hemolysis, where there's destruction of the red blood cells. So the second, if you look at this smear, it looks different from the first one that I had projected. It looks bizarre. The red blood cells are of different sizes and different shapes. So like this size of the red cell is not similar to this size of the red cell. This shape of this red cell looks elongated. This looks teardrop. So that is what is called anisopoikilocytosis. Aniso is the size, different sizes, and poikilo is the shape. They are different. So that's how it's reported in the peripheral smear. Then again, we look at the white cells. So this looks like a neutrophil. It has lobes or segments, and this is a small mature lymphocyte. And if you look at this mature lymphocyte and just look at a red blood cell, let's look at a spherical red cell here. It looks smaller than our small lymphocyte, and also the pale center seems to be much enlarged. So this is what is called microacetic hypochromic, because the red cells also appear pale. And then the platelets are scattered everywhere like dirt, and they even look clumped. So this is a microacetic hypochromic picture when you look at it under the microscope. And potential causes, there's a mnemonic I like to use. I see the little cells. Iron deficiency anemia, it should be top of the list, being the commonest type of nutritional anemia. Sideroblastic anemia is a differential thalassemia. Lead poisoning, though it's rare nowadays. Chronic infection, or even inflammation. So this gives you an idea of what could be going on. So the third morphology, the third smear you see here, this is a neutrophil, and you can see within the neutrophil, the lobes are 1, 2, 3, 4, 5, 6, 7, about 7 lobes or segments. And this is a small lymphocyte. This is our, as I said, the benchmark to look at your red cells. Now this red cell, if you look at this particular one, it looks actually appears bigger than the small lymphocyte. So, and the center, pale center is quite tiny. Other cells actually hardly have any pale center. So this is a macrocyte, and this is a hypersegmented neutrophil. And such films can be seen in situations, sorry. So these are macrocytic anemia, and in such, when you see such a film or a raised MCV, the potential causes could be nutritional, such as vitamin B12 deficiency or folate deficiency. And other conditions can include liver disease, hypothyroidism, alcoholism, and even Down syndrome. But this list is not exclusive. So back to the etiological classification of anemia. So the etiology, you can classify it in terms of three things you look for. Is there a decreased red blood cell production? So meaning a production failure, like it's the bone marrow is not able to produce the red blood cells to meet the body's needs. Is it an increased red blood cell destruction, meaning the red blood cells are being produced by the bone marrow? The bone marrow is functioning fine, but once they are released into the circulation, they are being broken down before their time. So that is called hemolysis. And then could it be blood loss? That is a third classification. So basically, is it a production problem? Is it a destruction problem? Or is it blood loss? So if we could start with the first one, decreased red blood cell production. We know that red blood cells are produced in the bone marrow from progenitor cell via the process of hematopoiesis. And the most common causes of anemia are related to deficiencies in the building blocks of the red blood cell, and the commonest being iron. But other nutritional deficiencies that can bring about anemia could be folate deficiency, vitamin B12, zinc, and copper. The next major group of production problem could be due to impaired erythropoietin production. Erythropoietin is a hormone that is produced by the kidney, and this actually stimulates the bone marrow to produce blood cells when they are required. So you'd find that there are situations where there's impaired production of erythropoietin, such as in renal disease or prematurity, or you could have a blunted marrow erythroid response to the erythropoietin. The erythropoietin is produced in adequate amounts, but it is not being recognized by the bone marrow. There's a blunted response. And this is seen mostly in anemia of chronic illness, in inflammatory bowel disease, rheumatological disease, because of just increased inflammation. And this inflammation brings about raised levels of hepcidin. Hepcidin is an enzyme that is when increased, it causes reduced absorption of iron, like in the gut, so bringing about anemia. The other group of production problem is bone marrow failure. The bone marrow is responsible for production of blood cells. So what happens when it fails? Then you tend to get not just an isolated anemia, but you could have also reduced production of the other blood cell lines, such as the white blood cells and the platelets. And this you could see that you'd have a pancytopenia in the blood counts when you do a routine blood count. And if you investigate, it could actually be a aplastic anemia or a pure red cell aplasia. That will just if you have an isolated anemia, or even constitutional hypoplastic anemia. And lastly, bone marrow infiltration can be a reason for bone marrow failure. So when you have blood cancers, hematological malignancies, such as leukemia, such as lymphoma, whereby you find these abnormal cells actually replacing the normal bone marrow cells in the bone marrow cavity. And this can actually bring about anemia or a pancytopenia. The second classification was increased destruction, where the red blood cells are being destroyed, what we call hemolytic anemia. And we can look at it in two ways. We can look at it as causes that are intrinsic to the red blood cell, that are within the red blood cell, like the red blood cell is abnormal And so the body is destroying it because it recognizes it as abnormal. So, so those are the intracorpuscular causes intrinsic to the red cell. And they're usually congenital in most cases. So red cell membrane abnormalities, such as spherocytosis, erythrocytosis, because the defect is in the membrane, the red blood cell membrane, can make the red cell prone to lysis by making them too round, too long, or just strangely shaped to pass through small blood vessels. So you'd find that these cells are actually being destroyed. The lifespan of the red blood cells is actually reduced. We know the red blood cell lifespan is about 120 days in adults. You might find it's even less than 30 days. The next abnormality could be an enzyme defect, enzyme within the red blood cell. We see this in G6PD deficiency. G6PD is glucose 6-phosphate dehydrogenase. PK deficiency is pyruvate kinase deficiency. So these are enzymes that are required for the red blood cell metabolism. And you find that now if they're deficient or absent, then this red blood cell is prone to lysis. Hemoglobin defect as well. The common one being sickle cell anemia. Others are like thalassemia, hemoglobin C, hemoglobin D, hemoglobin E diseases. So those are basically the three predominant intracorpuscular changes: membranopathy, enzymopathy, or hemoglobinopathy. So the second cause is extracorpuscular causes. These are extrinsic to the red blood cell, meaning the environment of this red blood cell. And you can actually classify them as, could it be a mechanical issue for those who have artificial prosthetic valves? They can cause sharing of those red blood cells and destruction. In hemolytic uremic syndrome or disseminated intravascular coagulopathy, that is DIC, this is, you have issues with the blood vessels and it causes mechanical trauma and leading to the sharing of the red blood cells. You could have immune causes such as antibodies reacting on the cell membrane, can lead to an autoimmune hemolysis. This can be seen even in acute transfusion reactions. So you get a transfusion, probably the transfused blood does not match your blood. And so the body's way of reacting is it will produce antibodies to destroy this blood that has been transfused to you. Hemolytic disease of the newborn includes ABO incompatibility or rhesus disease of the newborn. This is basically, you have antibodies in the mom that have been produced because of a foreign antigen in the child. And so then they'll go and attach to those antigens and cause destruction of those red cells, basically. Cases of infection can bring about increased destruction as well as sequestration when you have an overactive spleen that is pulling blood and destroying the blood. And the last and simplest category is blood loss, which is hemorrhage. Simply put, is if someone is losing blood or bleeding faster than new cells are being produced, then you'll have your net result will be a loss and subsequent anemia. The blood loss can be major, it can be minor, or it can be acute or chronic with ongoing losses. So any hemorrhage can cause anemia. This bleeding can occur during trauma, during surgery, or if you have gastrointestinal hemorrhage or GI bleeding, as seen in those inflammatory bowel disease or peptic ulcer disease, or even in post-menarcheal females or those who have heavy menstrual losses, you could see the bleed. There are also parasitic infestations, which tend to you lose blood slowly, gradually over time, and that is part of the chronic blood loss. So the bleeding disorders can lead to frequent hemorrhages and which accumulate into anemia. So sometimes with blood loss, it could manifest as an isolated anemia. Sometimes you can find that there is an low platelets, and once you see the low platelets and a low anemia, then you have to have a high index suspicion for even malignancies, because it's usually unusual to have both in just a minor or slow ongoing blood loss. And so we encourage that you actually do more investigations or refer for further workup. So the approach to establishing a diagnosis, you need to do a detailed history taking, thorough physical examination, especially if you're suspecting anemia, and lab investigations to confirm the diagnosis. So the clinical presentation of the patient depends on the severity of the anemia, but it also depends on the rate of the drop of the hemoglobin. So many patients with anemia, especially if it's mild, will be asymptomatic, and they are more likely to occur when there's an abrupt decrease in the hemoglobin, or in cases where the anemia is more severe. Some symptoms are more common to all types of anemia, and these are pallor, lethargy, just feeling tired, so fatigue, restlessness, headache. We know without enough oxygen being delivered to the tissues, the children will become weak and tired. They may even lose interest in normal activities. They lack concentration, probably have mood disturbances. They'll have failure to thrive, so poor growth, developmental delays. If there is an increased breakdown of the red blood cells, that is the hemolytic anemia, then they will present with yellowness of eyes, because we know the waste product of the red cells being destroyed is bilirubin, which stains the eyes yellow. And it also, as it's been passed out in the urine, excreted, then the urine tends to be dark. In situations where you have blood loss, then you'd have bleeding symptoms. This can include epistaxis, like nose bleeding. You could have like blood-stained stool, blood-stained urine, and even the skin petechia, those small reddish purplish spots on the skin, or even in the mucosal bleeding in the gums also. And when you have bleeding symptoms, you have to investigate for a potential malignancy. Cardiac failure is not usually, it's not an usual presentation. However, when you have like a major blood loss, it can cause more significant symptoms that suggest cardiac failure, such as tachycardia, like fast heart rate, fast breathing, like the patient just looks very ill. So as you're taking the history, there are certain things you have to take in consideration. Look at the age. In the newborn, a newborn who presents with pallor, the commonest cause is hemolysis, an increased destruction, or a hemorrhage. So if you find a child with jaundice, then you need to investigate for ABO incompatibility or rhesus incompatibility. If you're suspecting a hemorrhage, you could think of cephalohematoma, like a bleeding within underneath the scalp, an intraventricular hemorrhage, which is a bleeding within the ventricular system in the brain, pulmonary hemorrhage in the lungs, or even the umbilical cord. Sometimes you find children whose umbilical stumps have not been, they've not been clamped well, and they tend to ooze blood slowly and bring about anemia. Vitamin K deficiency, we see that commonly in children who are born at home, who don't come to the clinic, and so they could present with bleeding symptoms. Nutritional anemia is not seen at birth. I think that is a point to take home. So we start seeing nutritional anemia in the infants from about 4 months to 2 years. Hemoglobinopathies, such as sickle cell anemia, when the hemoglobin F starts levels start going down, that's when you start seeing this type of anemias. Fanconi anemia, it's a rare genetic disorder that leads to bone marrow dysfunction. It usually also presents around 4 to 6 years of age. So the first part, you look at the age. Then second, gender. Is there a trend? Is there some form of, if you're able to do the family tree, is there like, what can I say? Don't want to use a trend, but is there something that is occurring within that family among males? So you think of X-linked disorders which are inherited in the X-linked fashion. So things like the enzymopathies, G6PD deficiency, pyruvate kinase deficiency. So when you're taking that history, you want to look at the male cousins, the male siblings, maternal uncles, grandfather, mostly affects males, but it's not unusual to affect females for some various reasons. In the adolescence, then the girls, the females tend to be more affected. One, nutritional deficiencies, females, you want to look good, you don't want to eat so much, you do not want to gain so much weight, so you try and avoid certain foods, and this may bring about nutritional deficiency, and also consider the menstrual loss of iron. In the family history, you also, again, as you're drawing the family tree, you want to see whether there are certain conditions that could be inherited within that family. So we know most hemoglobinopathies and thalassemias are inherited in an autosomal recessive manner, meaning they are rare. You could actually have generations and generations and generations not actually being unwell, because then that means that most of them have just been carriers. And the risk of having actually a child with the disease is 25%, 1 in 4 chance. X-linked inheritance, again, that is mostly for the males. Male inheritance, autosomal dominant inheritance, such as hereditary spherocytosis, it's a 1 in 2 chance, so 50% chance. So it's actually much more common than the autosomal recessive. When you're taking that history, you want to know whether there are frequent blood transfusions, recurrent jaundice, gallstones, splenectomy, miscarriages. Those actually point out to probably increased destruction of the red blood cells. Ethnicity is important. We are living in it's like the world is a global village. There's migration. People are coming into Kenya, moving out of Kenya. And so you want to start looking at the ancestry of the patient. So we see the hemoglobinopathies are common in those other than of African origin, the Asians, Indians, African Americans, and Mediterranean descent. In Kenya, you ask where they're from. Most of the time, the sickle cell is much more common in the Western, Nyanza, and coastal regions. So for the diet, you want to know, especially in the young toddlers, you want to get information about how the baby was fed in the first year of life. It will be quite helpful. And this is with respect to breastfeeding practices. So was a child breastfed or was given iron supplemented formula or cow's milk? Timing of introduction of solid foods. You want to know, as well as timing of transition from breast milk or formula to milk. This is important because a full-term infant has enough iron stores for about the first 6 months, after which they require iron in their diet. You want to also know if the child is eating iron-containing foods, specifically what and how much. We know the iron-containing foods are things like green leafy vegetables, plant proteins such as bean, legumes, animal proteins such as white meat, red meat, eggs, fortified infant cereal, oats, etc. So you want to actually know what exactly it is that they are eating. You also want to get details about what they drink, including what kind of drink it is, if it's milk, what type of milk is it cow's milk, is it goat milk? You find that babies who are exclusively fed on goat milk tend to have folate deficiency. Those who are fed on excess cow milk tend to have iron deficiency, and we'll talk more about that. So you also want to know the quantities of that milk, because you find that the many toddlers who are called picky eaters, they consume large quantities of milk, and what happens is it fills them up, so they don't want to eat the more nutrient-rich foods. They feel full. And there are those who tend to have chronic diarrhea, and that could point out to a malabsorption problem. Pica is a strangely increased desire to eat non-nutritious, non-food items such as mud, clay, dirt, or like ice. So this actually can point out to like an iron deficiency anemia. You also want to look at the drugs the child is taking. There are those drugs that decrease production, such as penicillin, salicylates, non-steroidal anti-inflammatory drugs, and even the chemotherapy that we use for cancer patients. There are those drugs that increase destruction, such as aspirin or sulfur-containing drugs, especially in those patients who are known to have glucose 6-phosphate dehydrogenase deficiency, G6PD. And blood loss, mostly with the NSAIDs, overuse. It would lead to chronic GI bleeding. Infections, you need to look out for infections. Is there a history of fever? Is there, is there increased hemolysis, like a history of jaundice? It could point out to sepsis infection. So bacterial sepsis would lead to early destruction of the red cells, hemolysis, or bone marrow suppression, same as the viral infections. Parasites as well, such as malaria, Kala-Azar, and even worm infestation could lead to malabsorption and blood loss. So when you do a physical examination, you start off by ascertaining the severity. So the first signs you need to look for are the vital signs. So you look at the heart rate, the blood pressure, temperature, and the respiratory rate. You also need to look at the anthropometric measurements, that is the weight, length or height, and the mid-upper arm circumference. So if they are low, then it could suggest probably wasting or stunting or even malnutrition. So I put up some pictures for everyone to appreciate. This is a child who has pallor. So where do you look for it? You look for it in the conjunctiva. You look for it in the palms, which is easier to access. For physical examination, you could look at it. You look at the nails. In this particular picture, there's quelonychia, or what we say spoon-shaped nails, which are often brittle, and it suggests iron deficiency anemia. Other abnormalities of the nails, you can look at dystrophic nails, such as in dyskeratosis congenita, almost like an absent nail, just a nail bed. You look in the mouth. In this picture, you see a smooth tongue, and it's red. Most of the tongues, a normal tongue is rough. That is the papillae. So when the papillae are not there, that makes it a smooth tongue. You start thinking of iron deficiency anemia. Other changes in the mouth, you could see beefy red tongue in vitamin B12 deficiency, or recurrent ulcers. So those ulcers in the mouth, or a burning sensation when they take hot stuff, hot fluids, or spicy food, then it could point out to an anemia. And also the cracked lips, that is angular cheilitis. So facies, what you see in this picture, what actually stands out is the yellowness of the eyes, that's jaundice. an unusual large head with frontal prominence, malar prominence, that's the cheekbones, and even they have irregular maxillary teeth. Those are the hemolytic fasces. They could also present with a hepatosplenomegaly, which can point out to so many issues. Could be infections, even cancer. So you need to actually further investigate these children. Other things to look out for are swellings, whether in the neck or the armpits or the groin area, that's lymphadenopathy. Skeletal changes, you can look at the short stature. So that's where the anthropometrical measures come in. Microcephaly, a small head, or even the digits. In Fanconi anemia, you tend to have absent thumbs, or probably syndactyly, polydactyly. They could point out to the reason for the anemia. Skin changes can also occur, and also bleeding manifestations, as I mentioned. So once you suspicious of anemia, then you want to go ahead and perform some lab investigation. The common one, most routine we do, is the complete blood count. And I believe everyone has had a chance to look at this. So it looks at the three parameters, the white blood cell count and the differential. So the white blood cell differentials would be the neutrophils, lymphocytes, monocytes, etc. Then you'd look at the red blood cells and the red blood cell and the hemoglobin and the red blood cell indices. That's the MCV, MCH, and MCHC. And if you have a good heme analyzer, it actually interprets for you and puts for you whether it's low or high. So what is on the side written LH, that is just low values, or high values. As you notice there, the RDW, that is the red cell distribution weight, is high, 18.4. Normal value is about 12 to 14. So when you find a low hemoglobin, low MCH, and a high RDW, be very suspicious for iron deficiency anemia. Just a minute. Hello. Okay, so just to once you have that, then you can order for a peripheral film. As you see in this film, these are cells look smaller than the small lymphocyte. And if you look at this other peripheral film, then you see some abnormal red cells that are sickled. So that is seen usually in sickle cell anemia. And in the first film, that's iron deficiency anemia. In this peripheral film, again, the neutrophil segments are increased. The small lymphocyte there, the red blood cell is larger than the small lymphocyte. That is seen in macrocytic anemia. And in this peripheral film, what you see, the arrows are these red cells that look like they've been beaten up or chewed up or something, or fragmented red cells. And that is seen in microangiopathic hemolytic anemia. So once you have you're suspicious of probably a malignancy, or when you have pancytopenia, then you go ahead and do a bone marrow aspirated biopsy. In this first film, you look at the bone marrow, it looks empty, just filled with fat spaces and very little cells. Cellularity would probably be about 10% or so. So this is aplastic anemia. In this second film, you look at the white blood cells here in this bone marrow aspirate. They look uniform, they look huge and immature. So these are blasts, and you'd find it, you'd see in a situation such as in ALL, acute lymphoblastic leukemia. Reticulocyte count is important as it indicates bone marrow activity. Traditionally, it was done by supravital staining on fresh smears, but now it's measured through flow cytometry technology, which has been incorporated in the heme analyzer. So this table is just here for you to have a look at the normal reticulocyte counts for different ages. The newborns have a higher reticulocyte counts for obvious reasons that we've talked about, because of the high erythropoietin. They have an increased hematopoiesis, and actually it comes down to about 0.5 to 2.5% in adults. So basically, I put this diagram here for your own reference. So you can actually follow it and have an idea of the diagnosis. Same as this table that just looks at other tests that you can do, but most of them I have covered. I've put emphasis on what is important. So I had about 5 practical scenarios, but I think we can probably do 1 or 2 in the interest of time. So you have, yes.
Hi, let me make, is it okay if I make a suggestion?
Yes.
Because we have quite a few questions from our audience. How about we turn it into discussing those case scenarios? So there are a few people who have raised their hand to ask questions, and we can acknowledge those questions, and Dr. Wambui and I can look at the questions that are either in the Q&A or in the chat box. What do you think about that?
That is a good idea. That is okay. We can do that.
Thank you so much, Dr. Terry. So with that being said, we will look at Brian. Brian Ogal, you have your hand up. Please let me allow you to unmute your mic and please ask your question. Brian? Wambui, as Brian waits to ask his question, can you manage the questions that are in the Q&A? I will manage the questions that are in the chat. So you can ask the first one as Brian prepares to ask his question.
Okay, thank you, Dr. Mwendo, for the presentation. Our first question comes from Dr. Imran Kares. He says, greetings and thank you, Dr. Mwendo. I am tasked by questions from parents at 6 months prior to weaning with an incidental low MCV, low MCH, and borderline HB on how did my child become anemic? I have been breastfeeding. What could have gone wrong? So at what baseline do you decide between nutritional iron versus supplemental iron?
Okay, so thank you, Dr. Imran, for that question. Dr. Amboy, would you like to cluster out the questions or should I just answer individual questions?
Okay, so we can start with the first thing that he asked about at 6 months of age, was there a problem with the breastfeeding? Is there something she should have done? Okay.
All right, thank you so much. There was a study, there have been studies that have been done in Kenya, to be specific, and these studies actually help to inform even the census, the 10-year exercise that happens in Kenya. And they actually found that most of the mothers, whether they are pregnant mothers, lactating mothers, tend to be iron deficient at baseline. So you find that these mothers are giving birth to iron deficient babies. So for parents who've been breastfeeding exclusively for 6 months, and yet the child, even before the 6 months, has anemia, could think of such a reason. Most mothers are actually for the supplemental IFAS, the iron and phosphate. Ideally, they should start from when they be pre-conception, at conception, all the way through their pregnancy and even up to lactation for 6 months. However, what we find the practice is they stop at delivery. And so that could actually be one of the reasons why some children have low hemoglobins despite exclusively breastfeeding. It has also been shown that the iron content of breast milk, as much as it's easily available and absorbed better, it is not that it's not enough, and therefore you find that some mothers are opting for iron enriched formulas to feed their babies just for that reason. So I forget the values of how much iron content is in breast milk versus the formula. It is easily absorbed, but it might not be enough to meet the child's needs, and hence you find that. So when do you decide between nutritional iron versus supplemental iron? So this is what it depends on. It depends on a lot of parameters. The clinical, the history, and also the physical exam. Is this child symptomatic versus is this child asymptomatic? And also the laboratory investigations. Is this hemoglobin less than the -2 standard deviation? Then I would be more inclined to give supplemental iron versus just sending them to the nutritionist for nutritional counseling. So those are some of the things that you look at.
Thanks, Dr. So I'll read a comment and ask a question. So the comment is from Lucy. And Lucy's comment is nutritional anemia is most common among 6-month-old and 2 years. This could be as a result of poor introduction of complementary feeding, especially heme iron food sources. So I think that's what you were speaking about. Dr. Mustafa asked, well, first he said, thank you for an excellent presentation or review of anemia. Could you comment on the best or most efficient timing for a complete blood count check to rule out anemia?
Okay, thank you for the question, Dr. Mustafa. Actually, the AAP, the American Academy of Pediatrics, had suggested that there should be a certain age for screening for anemia. This was anything from 9 months to 1 year. However, that is still a suggestion. The verdict is out there. It has not been incorporated in many daily practice. So there's really no age limit or cutoff to do a routine blood count. However, you'd find that for this child from probably birth to 1 year, at one point in their life, a CBC would be done. Probably they are ill and well. And so at that point is where you can actually capture the anemia at that point. However, if it's a child who's been well and has not really had any doctor visits for illness, just the well check, then that is from anecdotal experience and data that is out there, I would say from 1 year, at the 1 year wellness check. Yeah.
Wambui, any questions from your side?
A question from Lucy Shege. When is the best time to introduce animal protein, such as red meat, during complementary feeding?
Okay, so that question, it's quite a tricky question, I would say. So there's no hard and fast rule about it, but however, we always encourage our patients, our parents and guardians to introduce complementary feed slowly and over time, meaning once they're at 6 months, then you probably want to ease into starting formula milk, maybe for a week or two before introducing something else like a cereal. And so it comes to a point where when you want to now introduce the solid foods, anything from 7 months, you might not want to start with the animal protein. So you'd want to just start gradually and probably monitor for any reactions to the food. So where you maybe start on animal protein and find there's probably a protein allergy or a reaction to the food, then you might want to delay the animal proteins because they're more allergenic than the plants. But whereby everything has been smooth, then you could then decide to introduce them anything from 8 months ongoing and going forward. However, with special attention, looking for any allergies, any malabsorption like diarrhea, skin rashes, and just how they are tolerating the protein. However, I always advise my patients that probably they want to start with plant proteins first, ease into the white meats before going to the red meat. That's my take.
Thank you, Dr. So guys, we're really big on time. So we are 2 minutes over. We'll go for 3 more minutes because there are quite a few questions coming in and there are a few hands that are raised. So the first thing is to Patricia. Patricia, do you have any questions live from Facebook?
Hi, Dr. Aisha. Not at the moment. We don't have any questions on Facebook.
Thank you so
Thank
much.
you.
Elizabeth, you have your hand raised. Your question, feedback, comment?
Not really. I just like the discussion. Thank you.
Thank you, Elizabeth. Irene? So as we wait on Irene, Wambui, on your side, do you have any questions? I have one comment. It says it would be right to send a message such as a deranged CBC, unexpected anemia may very well be an early marker to some oncologic or hematologic disorder. And this, of course, is coming from one of our neonatologists. So I would look for him and unmute his mic so that he can give his update. Wambui, in the meantime, you can ask your questions so that we're able to keep time.
The question from Caleb about major surgical procedures. How long does it take for the hemoglobin and the other red blood cell indices to come back up as they tend to go low during a major surgical procedure? How long does the body adjust to a normal HB?
Okay, thank you for that question. Usually for major surgeries, we know that even part of the workup or the considerations for that is you need to even have some blood on the side in case of any blood transfusion. But let's say that there's not been any transfusion, there has been low hemoglobin. If everything is fine in terms of your bone marrow is working optimally, there is the right building blocks, that is the nutrition, the right they have adequate, let's say, bone marrow activity, then it does not take too long. It varies from patient to patient, really. It varies even by age and even by gender, but whereby there is no there's no indication to transfuse, then that's a patient you want to monitor over time to see whether that hemoglobin is actually coming up. So I can't really say, is it gonna take 2 weeks? Is it gonna take a month? It really depends on how much blood loss and the certain patient characteristics for it and the bone marrow status for all that. You have to take that in consideration.
Thank you, Doc. I think with us being true to our word, we like to do something a bit different than what we normally do. So one, we'll close off this webinar with our house announcement. However, we would open the chat for everyone, meaning we'll unmute everyone's mic and you can have a bit of a discussion with Doc, because there are some important questions that are coming in after our timeline, and just so that we don't close out anyone. So on behalf of the entire team of AAR Hospital, we'd like to thank you for joining us today. We want to thank Dr. Mwendo for taking the time to join us and to give such an interesting presentation. Just a bit of housekeeping. On Saturday, the 26th, we'll have Equip Your Nanny and Caregiver Training. It's a first aid course for caregivers and nannies. It's at 2,800 Kenyan shillings. So please feel to call the hospital and register for the same. In keeping with our weekly webinar, on Thursday, we will have a webinar which is Common Pediatric Orthopedic Conditions, as we move into our orthopedic camp, which is the 24th to the 26th of February. With that, I will actually stop sharing live and then just open all our mics so that people who have questions can ask their questions, and those who have other engagement who expected us to be finished by 8 o'clock can be allowed to go into those engagements. Wambui, is that okay with you?
That's okay, Doc.
Okay, great. So Facebook is usually about 2 minutes behind, so we'll allow them to catch up. Patricia, once we are at the end, you let me know so that I can actually stop sharing so that it's not as blunt. So it's just a smooth transition, and I'll allow participants to actually be able to answer questions. So I'll unmute everyone and then we can all participate. I hope that's okay.
That's okay. I'll alert you.
Thank you so much.
Hi, thank you, Aisha, for facilitating it. Hi, Dr. Mwendo. Can you hear me?
Yes, I can. Hi, Dr. Mustafa.
Hi. So I'm just going to say out my comment aloud. Thank you once again for a very informative presentation. And I think it's very timely that you present this on World Pediatric Cancer Day. My comment was going to be, would it be a safe or a smart take-home message in saying that a deranged CBC can very well be a very pristine early marker for significant oncologic and hematologic disorders in kids?
Dr. Musa, I think deranged CBC or an unexpected anemia is grounds for further workup. Of course, having a hematological malignancy in mind, but it could as well be other conditions that are very much missed just because we probably overlook